Alright guys, let's get busy talking about polyhydramnios and oligohydramnios, which are going to be disorders of amniotic fluid within our amniotic sac. We're going to be talking about polyhydramnios and comparing it to oligohydramnios. We're going to be talking about some of the pathophysiology here in this column of our table, and then we're going to talk about some of our presentation and prognosis in the last column of our table. In terms of polyhydramnios, this is when we have too much amniotic fluid in our amniotic sac, and oligohydramnios is when we have not enough amniotic fluid in our sac, and we're going to compare and contrast these two in the same table. I want to start out by talking about amniotic fluid first, which is going to cushion the fetus and provide it with space to grow. So here we see that it's protecting our fetus and it supports growth throughout pregnancy. And in terms of understanding where amniotic fluid comes from and how it is processed is going to be so key in understanding poly and oligohydramnios. So it's important to know that amniotic fluid is produced from the fetal urine, and then it is going to be consumed or processed by fetal swallowing. And I want you to notice that the production is going to be like a urinary function, so I'm kind of highlighting it in this gold color, and then consumption is going to be a GI process, so I'm kind of highlighting it in that green color, because it's going to be really important in understanding the physiology that leads to these two disease processes respectively. So let's start out by talking about our polyhydramnios, which is going to be increased amniotic fluid within the amniotic sac. So if we were to draw like an imaginary picture of what this would look like, let's say we have our normal uterus over here, and then let's say our baby inside is taking up, let's say, about this much space. In the case of polyhydramnios, we have that same size uterine sac over here, but let's say our baby relatively is only taking up this much space, and everything else here is excess of amniotic fluid. This is by definition polyhydramnios, and so we can expect this from a couple of different reasons. Most of them are going to be related to GI, but some of them can be related to urine. So I'm going to be highlighting a lot in blue, but things that are related to the urinary system I'm going to highlight over in gold, and things that are related to the GI tract I'm going to highlight in green. So we can expect congenital anomalies as a leading cause of polyhydramnios, and I'm highlighting this in green because these are anomalies related to the GI tract. So these are going to be interruptions in ingestion, like tracheoesophageal anomalies and intestinal atresia. So let's draw a quick drawing, and this is going to be a rudimentary drawing. So here's my developing fetus, and then this is like its neck, and then here's like, let's say, its eyeball, right? What we're going to have is we're going to have our esophagus back here, which I'm going to highlight with a little E because we know this is a posterior structure. And then we have our trachea in the front, which is going to be more of an anterior structure, so I'm going to label it T. And what happens during development is we can have abnormal connections. So we can have a connection between these two structures, or we could even have like a blind esophageal pouch where like the esophagus only develops so far down and then it stops cold with like a layer of skin. And essentially these GI anomalies are going to prevent the fetus from ingesting amniotic fluid. So you can imagine that amniotic fluid could go ahead and come in here to the esophagus, but it would get stopped up by this GI anomaly and it wouldn't be able to continue. Now additionally, we can have intestinal atresia. So imagine that our error was a little bit further down here in the GI tract where we had our intestines fail to completely form. The amniotic fluid will be able to get down as far as the intestines and then it would stop, and from that point we would expect backflow up here, and then the amniotic fluid has nowhere to go except for the amniotic sac, and that's what gives us this picture here where we have excess fluid hanging around. We can also talk about anencephaly, which is when fetuses are in development and they fail to develop important parts of their cranial structures, and with this we're going to have a really rudimentary brain, and some of these patients have an absent swallow reflex. So in anencephaly we're going to have absent swallow reflex, and I'm highlighting this in green because this is a GI problem. If we cannot swallow that amniotic fluid, we cannot process it, and therefore it's going to get pushed back up and out into the amniotic sac. So this is another GI cause of polyhydramnios. Moving on, let's talk about fetal anemia, which I'm going to classify more as a urinary problem. So in fetal anemia, we don't have enough red blood cells to supply the fetus, and so the fetus's body is going to try and make up with this by increasing cardiac output to supply those tissues. And when we increase cardiac output, we are pushing more fluid through the kidneys, and this is going to create more urine. And so if we have this increased fetal urine output, this is going to be coming from the urinary tract. So we're increasing the amount of fluid that is pushing out of the urinary system, and that's going to create more fluid. And this is why I'm highlighting this one in gold, because it is due to the urinary system. Additionally, maternal diabetes can lead to fetal urine output, so this is going to be the same thing. It's going to be due to the urinary tract. This is not due to GI involvement. This is due to overproduction of urine, which is essentially overproduction of amniotic fluid. We can also expect to see something similar in multiple gestation pregnancies. We're going to have increased urine production because we have two fetuses that are both producing urine, and so they're going to produce a lot of amniotic fluid in tandem, and this is going to lead to polyhydramnios. And then lastly, we have twin-twin transfusion syndrome, which I'm going to highlight in pink because this is kind of a unique one. It's not necessarily GI or urine related. It's kind of a unique situation, and I want you guys to hold on to this because we're going to discuss it more after we talk about oligohydramnios. So just hold that onto your mind. We will revisit it here in a couple of minutes. So let's talk a little bit about the prognosis and management and presentation of our polyhydramnios. Frequently, these patients are asymptomatic. There's really not a lot of problems with too much amniotic fluid. It tends to be rather benign, and so we might see increased uterine size because the uterus is stretching to accommodate this extra fluid. But in terms of complications, we're really not going to have much. We might see increased amniotic fluid on ultrasound, but these babies are generally going to do fairly well despite having an extra amount of amniotic fluid. Now let's contrast this to our oligohydramnios, and let's draw another uterus here, and this time we're going to draw like our fetus being relatively this big, and so the fetus is still the same size, but I'm just trying to demonstrate for you guys that our amount of amniotic fluid here is going to be a lot less, and so there's going to be a lot less space for this fetus to grow and stretch out, and it's going to cause problems later on. So I want to go ahead and highlight again here like urinary problems versus GI problems, and you will notice that oligohydramnios is largely going to be all due to urinary problems. So I want you to notice like decreased urine output, urine output, urine output, urine output, no urine production, right? This is all about failure to produce enough urine, which is going to be the equivalent of failure to produce enough amniotic fluid. So let's go ahead through, and I'm going to highlight in red like the primary insult here in terms of why this is happening. So let's talk about uteroplacental insufficiency first. When we don't have a placenta that is supplying enough blood, we're going to have reduced cardiac output in our fetus, and we know that cardiac output is how much blood we can put through the kidneys, and if the kidneys are not getting enough blood, they're not going to make enough urine, and so this is going to lead to oligohydramnios. Additionally, if we have renal agenesis, a classic example of renal agenesis is going to be a patient who is pregnant and is taking ACE inhibitors, and that fetus is not going to develop kidneys. So that's an important thing to know here. Basically, renal agenesis or ACE inhibitor use is going to lead to no kidneys or kidneys that are very poorly functional, and we know that both of these are going to lead to kidneys or lack of kidneys to create urine, and so this urine production is going to be lower. So you'll see this continued trend of like not enough urine is following down all of this pathophysiology. Next, let's talk about obstructive uropathy. This is classically going to be a male patient that presents with posterior urethral valves, and essentially these are urethral valves that push urine back up into the kidneys. This is going to lead to a post-renal azotemia, and essentially this is kidney damage, and so we're going to have reduced fetal urine output due to this. So it's important to know that the posterior urethral valve here is the primary insult, and that's leading to reduced urine output. Then we can have autosomal recessive polycystic kidney disease. These fetuses are going to have poorly functioning kidneys because they are loaded with cysts, and so these are not going to be effective at producing urine. So again, same theme: kidney damage, non-functional kidneys, reduced urine output. And then finally, let's talk about twin-twin transfusion syndrome. I'm going to highlight this in pink like I did above. I asked you guys to hold on to this, and essentially what's happening in twin-twin transfusion syndrome is that we have two fetuses that are going to be sharing the same placenta, and this placenta is shunting blood abnormally. So it's shunting a lot of blood to one fetus and not enough blood to the other fetus. And we talked about how blood is related to cardiac output. So if one fetus is getting a lot of blood from mom, they're going to get a lot of cardiac output, whereas the other fetus that's not getting a lot of blood is going to have really low cardiac output. And so one fetus is going to be making a lot of urine, which is going to be this fetus here, and the other fetus is going to be making hardly any urine at all, which is going to be this fetus here. And so we can expect one fetus to have a lot of fluid in its amniotic sac and the other one to have very little in its amniotic sac. So this is going to present with polyhydramnios in one and oligohydramnios in the other. And we have a video specifically dedicated to twin-twin transfusion syndrome, which you guys should check out because we'll talk about some more interesting details related to that. But let's go ahead now and talk about the important findings in oligohydramnios in terms of presentation and prognosis. So unlike polyhydramnios, oligohydramnios has really poor outcomes, and it's going to be defined by something called Potter's sequence. And so I want you guys to notice that I have POTTER in bold here, and this is because oligohydramnios presents with a classic constellation of findings that are going to be really high yield on exam day. So let's go through each one. So let's start by talking about the first P, which is going to be pulmonary hypoplasia, and this is going to be due to lungs that cannot fully develop because A, there is no fluid, so there's no space. If we go back to this rudimentary drawing here, there's very little space here, and so we're going to get chest wall compression. And when we're compressing on the chest, the lungs don't have room to grow. And additionally, another important part of lung development is aspirating or breathing in the amniotic fluid throughout the pregnancy. And if there's very little fluid to breathe in, our lungs are not going to fully develop. So we have two things going on here. We have chest wall compression as well as lack of pulmonary fluid for aspiration, and this is going to lead to pulmonary hypoplasia, which is the first part of our mnemonic here. The next thing is going to be oligohydramnios, and this is just the root cause, right? So I'm going to add some red on top of here because this is like really what's causing the rest of Potter's sequence. Now let's talk about twisted face. So our twisted face is going to be defined by low set ears, retrognathia, which means like a jaw that's like set further back in the face, and then a flat nose. And all of these make sense, right? If you are a fetus inside of an amniotic sac with little fluid and little space, you can expect everything to just be smashed. So if you have a twisted face, it's because your face doesn't have enough room to develop and grow. And this is also going to transition to twisted skin. So you can expect to see like really significant skin lines that almost look like they've been twisted or smashed or compressed in a fetus with Potter syndrome. Also, we can expect to see extremity defects. So our extremity defects are going to be really high yield, especially club feet. Essentially, the fetus does not have room to like stretch out and move inside the amniotic sac, and this is going to cause extremity defects because of like shortened limbs and clubbed feet. And this is going to be pretty high yield, especially those club feet. And then finally, we're going to have our R for renal failure, and I'm going to go ahead and lump this in with red because this is usually the primary insult that we talked about here in terms of all these yellow decreased fetal urine output findings. This is because we have something that's wrong with the kidneys, whether it's not getting enough cardiac output or an insult due to a drug or renal agenesis or autosomal recessive polycystic kidney disease. These are all going to be renal insults, and so I wanted to include it in reds kind of as the primary insult causing the oligohydramnios. So it's important to know all the symptoms here of Potter syndrome. They're super high yield on the exam and they will come up, so really make sure you have those down. In terms of our high yield review, it's really important to understand this first part up here. Understanding that amniotic fluid is produced by the urine, which we kind of highlighted in gold, and then it's cleared by fetal swallowing. So in this green part, we talked about the GI stuff being related to green. And so with polyhydramnios, we talked about our GI causes, which we're going to be in green here. And this is basically failure to ingest or failure to swallow amniotic fluid, and it collects out in the amniotic sac. Whereas things related to urine production, increased urine production is going to make more fluid, whereas decreased urine production, which was everything down here, is going to be a reduced amniotic fluid load. And so that's something to know. And then it's important to know that all of this reduced fluid is going to lead to Potter syndrome, and that polyhydramnios, on the other hand, is going to be largely asymptomatic and benign.